Welcome to the deep dive. Today, we're diving into a topic that's really common, maybe more common than you think, and definitely important, especially if you're prepping for something like the MSRA exam.
Yeah,
We're
absolutely.
going deep on adult seborrhoeic dermatitis.
And we've got some really high-yield focused info lined up. Think of this as your essential revision guide, but, in audio form.
Exactly. Our mission today is basically to cut through the noise, give you the absolute key facts about seborrhoeic dermatitis in adults. So, what it is, why it happens.
What it looks like, how you manage it.
Right, all that stuff. It's
Yeah.
really about getting those core details to stick, whether it's for an exam or just so you're properly informed. Okay, so let's just jump right in then. At its most basic, what exactly is adult seborrhoeic dermatitis?
Well, at its core, it's a really common chronic inflammatory skin condition.
Chronic, meaning it sticks around, it's not a one-off.
Exactly, that's key. It tends to have periods where it gets better, then worse again, and it specifically affects areas of skin with lots of sebaceous glands.
The oil glands.
Yep. So think the scalp, the face, the chest, sometimes the upper back too.
And what does it actually look like? What would you see?
Okay, the hallmark is red, scaly, itchy patches. But the type of scale is really characteristic. It's usually described as like greasy or maybe yellowish scales on top of that redness.
Greasy scales. Okay.
And it's really important to remember it's not contagious. You can't catch it from someone.
Right, that's good to know. Now, I've heard it's often linked to a specific yeast, Malassezia. Tell us about that connection.
Yeah, that's right. Malassezia furfur yeast, you might also see it called Pityrisporum oval. It's strongly implicated.
Implicated how?
Well, the exact cause isn't fully nailed down, but the thinking is that an inflammatory reaction in the skin to this yeast, maybe an overgrowth or just how the body reacts to it, plays a really big role.
So the yeast itself isn't the problem, it's the reaction.
Pretty much.
Hmm.
It's considered a benign scaling rash, usually starting sometime after puberty.
Okay, so if the exact cause is a bit of a puzzle, what do we know contributes? What are the big factors?
It's definitely multifactorial, not just one single thing. So yes, you've got the Malassezia yeast overgrowth or sensitivity.
Okay.
Then there's an abnormal immune response in people who are susceptible. Genetics probably plays a part.
Runs in families sometimes?
Can do.
Yeah.
And the activity of those sebaceous glands is crucial too, because that's the environment the yeast likes.
So it's kind of a mix of things coming together.
Exactly. Your body mounts this inflammatory response to the yeast in those oily areas.
Yeah.
And that's what leads to the skin changes we see. It seems like some people's immune systems just overreact to this really common yeast.
What about things that make it worse? Like triggers?
Yeah, definitely things can aggravate it. Stuff like being ill, stress is a big one, fatigue.
Stress, always stress.
Tell me about it. Seasonal changes too often worse in winter. Having a weakened immune system for any reason. Even some medications can trigger it.
Okay.
And we also see it more often and sometimes more severely in people with certain neurological conditions. Parkinson's disease is the classic example.
And Parkinson's.
Well, the thinking is that immobility might contribute to sebum sort of building up, making it a better environment for the yeast.
Interesting. And dandruff, where does that fit in? Is it just mild seborrhoeic dermatitis?
Pretty much, yeah. Dandruff or pityriasis capitis is basically considered a non-inflamed form just on the scalp. You get the scaling, but usually not that significant redness you see in full-blown seborrhoeic dermatitis.
So related, but less severe.
Exactly.
Right. Who's more likely to get this then? Are there specific risk factors we should know about?
Definitely. There are known risk factors. So
Yeah.
having a family history bumps up your chances.
Makes sense.
Having oily skin, which is logical given where it pops up.
Yeah.
And then certain medical conditions really increase the risk. We mentioned Parkinson's.
And HIV.
Yes, HIV is a big one. The rates are much, much higher in people with HIV.
Yeah.
And it can be more severe too.
Yeah.
That's a really key association to remember.
Okay. HIV, Parkinson's, what else?
Stress, definitely a risk factor and a trigger.
Mm-hmm.
And generally having a weakened immune system from any cause.
In age. You mentioned it starts after puberty.
Yeah, it has this interesting pattern. It's really common in babies. That's cradle cap. Then it can peak in adolescence. And then there's another major peak in adults, typically between 30 and 60 years old.
Got it. Infants, teens, and middle-aged adults.
That's the pattern.
Okay, let's dig a bit deeper into the pathophysiology. What's actually happening sort of under the skin?
Right. So it really comes down to that interaction we touched on. You've got the Malassezia yeasts, which live normally on most people's skin.
Okay.
They feed on the oils, the sebum, produced by those sebaceous glands. Now, in someone who's susceptible, their immune system seems to recognize bits of this yeast or stuff it produces and kicks off an inflammatory response.
Like an overreaction, you said.
Exactly, like an exaggerated response. And that inflammation is what causes the skin cells to turn over faster, leading to the scaling, and it also causes the redness and the itch.
And the link to HIV and Parkinson's? How does that fit pathophysiologically?
Well, it likely relates to how those conditions affect either the immune system, like with HIV, the immune regulation is off, or maybe sebum production, or its composition, like potentially in Parkinson's. It just makes individuals more prone to this inflammatory reaction.
Okay, that makes sense. So we've got this picture. Red, greasy, scaly patches, especially in those oily zones. But, lots of skin conditions can look kind of like that.
Absolutely.
So for revision, knowing what else it could be, the differentials, that's super important, isn't it?
Oh, definitely. This is a key area.
Yeah.
While, often you can diagnose seborrhoeic dermatitis just by looking, especially in a typical case, you have to consider other possibilities.
Yeah.
Especially for exams.
So what are the main ones?
The big ones that can look similar are psoriasis, atopic dermatitis, that's eczema, contact dermatitis, and various fungal infections like ringworm.
Right. How do you start to tell them apart?
Thinking about the location is really helpful, just like you would in clinic.
Okay, give us some examples. Say, on the face.
Okay, on the face, besides seborrhoeic dermatitis, you might think about rosacea. That usually involves redness and flushing, maybe some spots, but typically doesn't have that prominent greasy scale.
Okay.
Or even something like lupus, which can cause a facial rash, though that's often more triggered by the sun.
And the scalp? That's a common spot.
Yeah, the scalp is key. Psoriasis is probably the #1 differential there. And sometimes they can even overlap, which gets confusingly called sebum-psoriasis.
How's scalp psoriasis different?
Typically, psoriasis scales are thicker, drier, and more silvery white compared to the greasy, often yellowish scales of seb derm. Psoriasis also often affects the elbows, knees, lower back, places seb derm usually doesn't.
Okay, thicker, silver scales. Think psoriasis. What else on the scalp?
You'd also think about maybe infected eczema or tinea capitis, that's fungal ringworm of the scalp.
Right. And on the torso, chest and back.
Yeah, the list gets a bit longer there. Could be atopic eczema, often drier in maybe different spots like elbow creases. Could be contact dermatitis if it's localized where something touched the skin.
Okay.
Maybe pityriasis rosea, which has quite a distinct herald patch and Christmas tree pattern usually. Pityriasis versicolor, another fungal thing, often causing pale or dark patches on the back and chest. Lichen simplex, which is thickened, itchy skin from chronic scratching. Or candidiasis, a yeast infection, often in skin folds.
Wow, okay, that's quite a list for the torso. So the key is really looking closely at the type of scale and the exact location.
Exactly. Combine the location, those classic sebaceous gland areas like scalp, eyebrows, nasolabial folds, chest, with the quality of the rash. Remember, red base, greasy or yellowish scales. That's your classic seb derm picture.
So let's try a mini vignette, like for revision. Say a 45-year-old man comes in, itchy scalp for months, greasy, yellowish scales, also got some redness and flaking around his nose and in his eyebrows, most likely diagnosis.
Bingo. Greasy yellow scales on the scalp, plus facial involvement in those classic spots in nasolabial folds, eyebrows. That pattern shouts seborrhoeic dermatitis.
But if the vignette said thick, silvery scales on the scalp and patches on his elbows?
Then you'd be leaning much more towards psoriasis. See how the details matter.
Got it. Greasy plus typical location, likely seb derm. Okay, let's talk numbers. How common is this? Globally, UK?
It's really pretty common. Generally, sources say it affects somewhere between maybe 1 to 5% of the global population. Some figures put it around 2% overall.
Okay.
But as we keep saying, the big headline in epidemiology is that huge difference in people who are immunocompromised.
Right, the HIV link.
Exactly. In people with HIV, the prevalence just rockets up. Figures like 34% to even over 80% are quoted. And it tends to be more widespread and severe, especially with advanced HIV or AIDS. That's a critical link.
Any difference between men and women?
Yes. Generally, it's more common in males.
Why is that?
The thinking is it might be linked to male hormones, androgens, influencing the sebaceous glands to produce more oil, creating that favorable environment.
Okay. And just to recap those age peaks again.
Yep. Infants, cradle cap, then adolescence, and then that big adult peak, usually 30s to 60s.
Right. We've touched on the general look, but let's get really specific about the clinical features. How does it present in those different areas?
Okay, let's break it down. Again, always thinking. Red base, greasy yellowish scale. Location is everything.
Face first.
On the face, Classic spots are the nasolabial cake, folds those lines from nose to mouth, over the bridge of the nose, in the eyebrows, the central forehead, even the eyelashes. That's called seborrhoeic blepharitis. It looks like inflamed, maybe slightly greasy patches with fine scales.
Okay. And the scalp?
Scalp is probably the most common site. It can range from just simple, dandruff-fine, white scaling to more obvious, ill-defined pink patches with thicker yellowish or white scale. It can affect just part of the scalp or the whole thing. Itch is really common here.
Yeah, itchy scalp sounds miserable. What about chest and back?
On the chest and upper back, you might see small, sort of reddish-brown bumps with greasy scales, often around hair follicles, or you can get larger, more defined patches. The area right over the sternum, the breastbone, is a really classic spot.
Okay, sternum. Good tip. And flexures, like armpits.
Yeah, in the flexures, armpits, groin area, under the breasts, sometimes behind the ears. It tends to present as just red patches, maybe some bumps or plaques. Because it's in a fold, it might look a bit moist and can sometimes resemble interfrigo, which is just irritation from skin rubbing on skin.
So the appearance can vary a bit depending on the location, but that greasy scale and redness in oily areas is the theme.
Exactly.
Now, how do doctors actually diagnose this? Do you need lots of tests?
Well, good news here. For exams and practice diagnosis is usually pretty straightforward. Most of the time, it's a clinical diagnosis.
Meaning you just look at it, take a history?
Yep. Based on the characteristic appearance, that rash we described, and where it is on the body, plus the patient's story, the itch, any triggers they've noticed, if it comes and goes.
So usually no blood tests or biopsies needed?
Not routinely, no. Specific investigations aren't typically required if the picture looks typical.
When might you do a test then?
Really only if the diagnosis is uncertain, or if you're actively trying to rule out one of those differentials we talked about.
Like the fungal infection?
Exactly. If you suspect tinea capitis on the scalp, or maybe pityriasis versicolor on the chest, you might do a skin scraping. You scrape off a few scales, send them for microscopy and culture to look for fungus.
And a biopsy?
Very rarely.
Yeah.
Maybe if it looks really unusual or isn't responding to standard treatments, and you're still scratching your head about the diagnosis after considering the common stuff.
Okay, so mostly clinical diagnosis. Once it is diagnosed, how do we treat it? What are the main goals?
Right, the goals are pretty clear. We want to, 1, control the symptoms like the itch and scaling. 2, reduce the inflammation and redness. And 3, basically clear up the rash during those flare-ups. And topical treatment stuff you put directly on the skin are absolutely the mainstay.
Yeah.
Creams, shampoos, lotions.
What kinds of ingredients are in these topicals?
2 main types. First, topical antifungals. Things like ketoconazole or cyclopirox. These target that Malassezia yeast.
Okay, tackling the yeast.
Yep. And second, topical corticosteroids. These are anti-inflammatories. They calm down the redness and the itch, usually used just for short periods during a flare.
What about specifically for the scalp? Any particular approach?
Yeah, there's often a stepwise approach recommended, like in the nice CKS guidance. You might start with over-the-counter shampoos containing things like zinc pyrithione.
Like Head and Shoulders.
Exactly, or coal tar shampoos. If those aren't cutting it, then you step up to medicated shampoos like ketoconazole shampoo, maybe used a couple of times a week. Selenium sulfide shampoo is another option. And you can also get topical steroid lotions or gels specifically for the scalp if the inflammation is bad.
Okay. And for the face and body, similar idea?
Similar principle, yeah. Topical antifungal creams like ketoconazole cream, and again, topical steroids, but usually milder ones on the face, used sparingly and for short bursts to manage flares.
You mentioned it's chronic, so flares are common. How do you manage that long term?
That's the challenge. Because recurrences are so common, treatment often involves not just treating flares when they happen, but sometimes using treatments regularly to prevent them.
Like maintenance therapy?
Exactly.
Yeah.
Maybe using an antifungal shampoo once or twice a week, even when the scalp is clear. Or intermittent use of a topical steroid if needed. The combination of regular antifungal use with intermittent steroids is a common strategy.
Any other options?
Yeah. Another class of topicals sometimes used, especially on the face where you want to avoid too much steroid, are calcineurin inhibitors, things like tacrolimus or pimecrolimus. They also reduce inflammation, but work differently from steroids. They're increasingly seen as a good alternative or addition.
Okay. What if it's really severe? Like widespread or just not responding to topicals?
For those more severe or resistant cases, you might have to consider systemic treatment as pills. Oral antifungals like ketoconazole tablets can be used. Sometimes oral antibiotics like tetracyclines are used, not really for infection, but for their anti-inflammatory effects. And then in really difficult, rare cases, things like oral isotretinoin, the Strong acne drug or even ultraviolet light therapy might be considered, but these are definitely specialist treatments.
And you mentioned that link again, if it's severe or atypical.
Yes, absolutely crucial point, especially for exams. Severe, widespread, or atypical seborrhoeic dermatitis. You must consider testing for underlying HIV infection. That association is just so strong.
Got it. Okay, moving towards the long-term outlook, what's the prognosis generally like?
Well, like we said right at the start, it is a chronic condition. So unfortunately, it doesn't typically just vanish forever on its own.
So no cure.
No complete cure as such. What people can expect is a course that waxes and wanes. Periods where it flares up, the rash is active, and periods of remission where it clears up or is much quieter.
But it is manageable.
Yes, that's the good news. While there's no cure, it usually responds well to the treatments we've discussed. Effective symptom management is definitely achievable for most people. But you have to anticipate those relapses. They're just part of the deal. Managing expectations is important.
Okay. And does it lead to any serious complications usually? Anything dangerous?
Generally speaking, no. The sources usually say there aren't typically serious physical health complications directly from the derm itself.
But it can affect quality of life.
Oh, absolutely. The itch can be really bothersome, sometimes burning sensations. And because it's often visible face, scalps, it can definitely have a significant impact on quality of life, cause emotional distress, affect self-esteem. We shouldn't underestimate that.
Any risk of infection?
Yes, there's a risk of secondary bacterial or fungal infection developing on the inflamed skin, especially if it gets scratched a lot and the skin barrier is broken. And then, very rarely, in really severe cases again, often linked to things like immunosuppression or maybe severe heart failure, it could potentially progress to cover most of the body surface with redness and scaling. That's called generalized seborrhoeic erythroderma, but that's quite uncommon.
Wow, okay. That was a really comprehensive run-through of adult seborrhoeic dermatitis. We've covered, well, everything from the potential causes that Malassezia yeast, the immune response to what it actually looks like, those greasy scales in specific spots.
Yeah, and how to tell it apart from other things like psoriasis, which is key.
Definitely. And the management, that stepwise approach, focusing on topicals first.
Absolutely. Understanding those core features, greasy scale, location, Malassezia link, those HIV Parkinson's associations, that's gold dust for recall, especially in an exam.
And I think knowing it's chronic but manageable, that treatment is about controlling flares, maybe some maintenance. That's a really important take-home message.
Totally agree. And remembering diagnosis is usually clinical that saves unnecessary tests. It's common, so you'll definitely see it. Being comfortable recognizing it and knowing those first steps is super useful.
So what does this all boil down to for you listening? Hopefully a much clearer, more structured picture of adult seborrhoeic dermatitis. Remember the key takeaways. Greasy scales, those typical locations, scalp, face, chest, the Malassezia connection, and think about those associated conditions like HIV and Parkinson's, especially in severe cases.
And keep those main differentials, especially psoriasis, in the back of your mind when you see a scaly scalp. Knowing the typical treatments, antifungals, short-term steroids, and that clinical diagnosis rule, those are really high-yield points.
Okay, a final thought to leave you with then. Given how closely this seems tied to Malassezia yeast and the individual's immune reaction, what might future research look like? Could we see maybe more targeted treatments, perhaps something that deals with the yeast more specifically, or fine-tunes just that bit of the immune response without knocking the whole system? Something to think about.
For more free MSRA revision resources, do visit freemsra.com. And if you're looking for the full premium revision toolkit, head over to pastmsra.com.